Hello, and welcome to the Evelyn Y. Davis studios of the National Press Foundation in Washington, D.C. My name is Rachel Jones, and I'm the Director of Journalism Initiatives for NPF. Thank you for joining us for the Is Your COVID Shot Covered webinar, sponsored by the COVID Vaccine Education and Equity Project, whose You're Covered initiative has media resources and a diverse network of 250 plus partner organizations to answer urgent questions about the latest vaccine-related guidance. For more information, you can scan the QR code or go to covidvaccineproject.com. Even as we're participating in this event, members of the CDC's Advisory Committee on Immunization Practices are meeting to decide the release date of the newest COVID booster shot. This comes after the world has emerged from a deadly pandemic that claimed nearly 7 million lives and pushed healthcare delivery systems around the world almost to the brink. Just yesterday, the FDA approved updated COVID vaccines from Pfizer and Moderna, targeting the Omicron variant XBB.1.5. And the Biden administration said last month that it expects that these new vaccines will be available to the public by mid-September. But as these new variants emerge and the numbers begin to rise again, how can members of the public stay informed about where to obtain vaccines and whether they'll be covered by insurance or through other channels? Our panelists today are going to help us get a better understanding of the post-COVID vaccine emergency landscape, and they're going to provide some much needed context for journalists and the public. First, Patricia D'Antonio is Vice President of Policy and Professional Affairs for the Gerontological Society of America, and she's a board-certified geriatric pharmacist. Trish directs GSA's policy initiatives and is responsible for developing relationships with organizations in the aging area. She's also co-chair of the Adult Vaccine Access Coalition, which advocates for federal policies to improve access and usage of vaccine for adults. Next, Dr. Mario Ramirez is a senior consultant for the law firm Akin Gump and managing director at the nonprofit Opportunity Labs and a practicing emergency physician in Northern Virginia. He previously served on active duty with the U.S. Air Force in Afghanistan before joining the U.S. Department of Health and Human Services as a White House Fellow from 2014 to 2015. During his time at HHS, he served as the acting director of the Office of Pandemic and Emerging Threats within the Office of Global Affairs, where he was involved in the responses to the global Ebola, MERS, and SARS outbreaks. And Alexander Tin is a digital reporter for CBS News, covering the Biden administration's public health agencies, including their response to infectious disease outbreaks like COVID-19 or Mpox. Thank you all for joining us today. Now, for everyone tuning in, you can submit questions for these panelists at any time in the chat or using the Q&A feature in Zoom, and we will try to get to as many of them as we can. Now, first, because of today's CDC meeting, I'd like to start off by asking Patricia to give our viewers some background on the Advisory Committee on Immunization Practices and just what its role has been during the pandemic to ensure that vaccines are available.
Rachel, thanks so much, and thank you for holding this webinar today and for inviting me to participate on behalf of the Adult Vaccine Access Coalition and the Gerontological Society of America. I think it's really important for us to understand the process for vaccine approval and how vaccines come to the public. You already mentioned prior to the Advisory Committee on Immunization Practices review, the FDA, the Food and Drug Administration, conducts its reviews and approves the drug. And so once the FDA approves the vaccine, It is then forwarded to an advisory committee that's made up of medical and public health experts who develop a recommendation for how we'll use the vaccine in the United States. So this is one place where we see an FDA review, and then furthermore, the advisory committee on immunization practices, or what we genuinely call ACIP, right? So we all have our abbreviations. So the ACIP will meet, and they will review the recommendation that's approved by the FDA, right? So they're already, the drug is already approved, the vaccine's approved. What ACIP looks at are there certain age groups that we should consider for a vaccine, right? And sometimes we're talking about older people over the age of 60, people over the age of 65. Sometimes we're talking about children, right? Or adolescents, right? And looking across the life course for appropriate and best ways to use a vaccine so that it is effective, right? For specific ages. After the ACIP also looks at how the vaccine prevents disease, and are there ways that we can make sure that we are preventing adverse events in children or in adults. And then another question that they may ask is if somebody gets the disease and there is no vaccine, what's the benefit, right? So one of the ACIP's tasks is to determine if a vaccine has a public health benefit, right? That's why sometimes we'll see a vaccine is recommended for a certain age group or certain population, right? After ACIP makes their recommendation, the CDC director then decides on whether to approve the recommendation. Once the CDC director approves the recommendation, then it's available for all of us to be able to take advantage of that vaccine. So it's a really important process in our public health system, and I think we may have become more aware of it through the public health emergency and through COVID. This has been the case for all vaccines. So think about flu, think about pneumococcal vaccine, think about shingles vaccine. This is the case for all vaccines.
Let's go to Mario next. As someone with experience in the federal health policy realm, what would you say are the most important lessons that officials have learned about public health delivery from the pandemic, and whether this new round of vaccines is actually going to be part of an ongoing strategy going forward?
Yeah, thank you, Rachel. That's it's a very big question, that I think we could spend the whole hour talking about, but I won't. I think there are a number of lessons that we probably should draw from this that I think officials have seen. I think from a broad biosecurity and kind of biodefense perspective, a lot of people would say that the three pillars of any sort of response are, data collection, having a good testing strategy for detection, and then the third leg would be sort of treatment and management of infected or sick persons. And I think vaccines and drug development are probably the leg where we've made the most progress during this pandemic. I think there are now steady work streams that have been institutionalized through the ASPR and BARDA and some of these other organizations that people are aware of. Testing, I think, is still a little uncertain. If we look back on where testing came from at the start of the pandemic and the sort of, I would say, bureaucratic hurdles that got in the way, as well as some technical difficulties, it's not clear that those problems have been completely fixed. And there's a piece of legislation out there, the Ballot Act, that has, an important role to play here, and that's still being heavily debated. But the first leg, data, and really understanding where people are infected and where waves are going, that part is still, I think, unaddressed, unfortunately. And this was an area that was unaddressed when I was there at HHS, and we saw play out during Ebola. What's clear, I think, coming out of this pandemic, right, is that CDC is not an operational organization the way that I think a lot of the people in the public and the way that a lot of our government officials think that it is, both because of its geographic location in Atlanta, but also by virtue of the authorities that it has to actually collect data and the limitations in those authorities, it doesn't have the ability to continue to collect data after a public health emergency ends. And that part still hasn't been addressed. And on the treatment perspective, right, as somebody who sees patients in the ER, without having good data about where outbreaks are headed next, it makes it harder to address those other two legs of that trifecta. So, I think that the vaccines are an important part of this going forward. There are important lessons that have been learned there, but there are still other areas where we have a lot of work to do.
That is absolutely a fascinating point for me to consider as someone who lived in East Africa for a decade and understanding how health systems there were challenged due to the lack of evidence and data. I'm really surprised to hear that we're almost in the same boat. Alex, as a journalist, I am very interested in hearing about how reporting on the pandemic has affected your career and how you're managing to stay abreast of the incremental research findings on virus strains and vaccine efficacy, et cetera. Can you tell us a little bit about that?
Yeah, well, on the career side of it, I was a campaign reporter before this. Going into the COVID pandemic, they said, oh, can you help us out on this coverage on this topic? And I thought, okay, maybe it's going to be a couple months that I'm going to be focused on this. And it's essentially turned into my new career path at this point, which I'm not complaining. I really enjoyed it. It's super interesting. I love every minute of it. In terms of keeping up with, the latest developments, it's a couple things, right? A lot of it comes through social media. The platform called X, formerly Twitter, a lot of experts are still on there talking about, for example, BA.2.86, the latest variant. There was a lot of information on that platform before it was elsewhere. Preprints remain a very important thing for anyone who was covering COVID earlier. It's still become this major way that scientists are sharing information on these servers long before it's published in official scientific journals. And then obviously paying attention to what we're hearing from health agencies. The CDC is one example, picking up on what Dr. Mario was talking about just a couple minutes ago, has really made an effort, I think, in the past couple months to do a better job at sharing information about viruses and outbreaks as they are unfolding. You saw that happen with the BA.2.86 variant, where basically every week they were putting out what was essentially a highly detailed blog post, similar to what you might have seen in the United Kingdom, saying, here's what we know, here's what we don't know, and here's what we might know soon based on X, Y, or Z tests or experiments or data about this variant and whether or not we should be worried about it.
As we start to see COVID cases increase, I'm just wondering what type of impact should we be expecting in the near term and months ahead? Should we start to be worried? I'll ask Dr. Mario to answer that one.
I think that, we are likely to see a continuing increase in cases in the weeks ahead. As I sort of alluded to earlier, our insight into what's actually happening out there with disease spread is quite a bit more limited now than it was just a few months ago. With the end of the public health emergency, mandatory reporting from several state authorities has been pulled back. And so that really, I think, puts us several weeks behind a sense for where the virus is actually spreading, because we get hospitalization data several weeks later, we get death data several weeks later. One of our other surrogates right now, wastewater reporting, is helpful, although that's still a fairly inexact science. And so I think when you look at the macro trends, most of us feel like cases are continuing to increase and really not showing signs of leveling off. But it's important to put that in context and say, well, what does that look like compared to other either waves or surges, depending on your viewpoint? And I think you have to acknowledge that it's quite a bit lower or less than other waves or surges that we've had in the past. And the amount of severe disease is quite a bit lower. And so what I think we're likely to see are a much greater number of relatively mild or asymptomatic cases, probably an increase in hospitalizations, but an overall lower fatality rate than we saw with earlier waves. Now, that, of course, is not meant to detract from the hundreds of Americans who die from this on a daily basis. And I see this all the time in the ER. I think, as many people have said before, COVID is with us to stay, just as many other viruses are here with us to stay as well. And that, unfortunately, is a reflection of the world that we live in.
I think personally, coming from a journalist perspective, when I think about covering this topic, the main challenge at this point is a public that was in constant emergency mode, and you could go to the CVS or go anywhere and get what you needed because of that emergency crisis. But now I wonder, Patricia, what is there a sort of a baseline understanding for the public about how vaccines will be covered? What's changing about that process? And do we all really need to give ourselves a primer on insurance coverage?
So thanks for that question. And I can't agree more with Dr. Ramirez on his comments around how we have to remain vigilant and know what's going on in our community with respect to COVID and with other respiratory viruses that we know can impact us this season. One of the things that I think is really important is we need to start to think, as we've transitioned from public health emergency to how we're going to move forward, is that we need to think about COVID as one of the respiratory vaccines that we would regularly get in a season, and how that plays out. We'll know better after this afternoon with ACIP. But this is an updated vaccine, right? So we have to think about COVID like we think about the flu vaccine. What we are fortunate is that for private insurance, all ACIP recommended vaccines are required to be available at no cost to the recipient, the consumer, the patient, right? Also for Medicare, the same applies. And in October 1 in Medicaid, that it applies that the COVID vaccine is covered at no cost, similar to other vaccines based on law passed last year in Congress. There's also, so what we know is that 9 out of 10 Americans are covered and have a no cost option to obtain the COVID vaccine this season. There's 1 out of 10 people who are uninsured or underinsured, and CDC and the Biden administration have worked to develop a bridge program that will make COVID vaccine available this season up until 2024 at no cost. So again, think about this. We need to make sure that the coverage is out there so that we're not that someone is able to have the vaccine on board to help prevent or reduce the impact of COVID if they choose to get the vaccine. So we really are working in this next year. There's a transition that's happening, right, for us to all be able to have access to the vaccine. I know that there were some resources, I think, that were chatted in from the COVID vaccine project, and there are resources that we'll be sharing after the webinar as well that talk about how different private insurance, Medicare, Medicaid are covering the COVID vaccine, and then this bridge program from CDC will cover COVID for underinsured and uninsured Americans.
And Rachel, if I could just jump in on one thing that Trish said, I think a lot of times, and especially before the pandemic, ACIP meetings were not sort of widely attended or not really necessarily viewed with a whole lot of fanfare. But I think Trish is making the great point that this meeting this afternoon has actually critical importance. And for reporters who are on the line, the nuance here is that many insurers and many federal programs cover vaccines that have been recommended by ACIP. And ACIP is the committee that decides who should get a vaccine. Even though the FDA may fully license a vaccine for everyone, the decision about who it's recommended for actually has a key importance on coverage. And so if for whatever reason ACIP were to come out today and say, and there are vocal proponents of this theory who believe that the vaccine should only be recommended for older Americans because that would increase uptake. That's a viewpoint that I disagree with. But if they make that recommendation, there is a pathway where private insurers and other people can say, well, these vaccines are not recommended for everyone, and we're not going to provide coverage. And how we see that play out over the next few weeks is critically important to watch.
Alex, I'm wondering, in the newsroom, from the view from there, what are editors interested in hearing about this vaccine issue? Is it sort of keeping us abreast of the research? Is it, excuse me, whether we're focusing more on children and youth? Is it the uninsured angle? What would you say that editors are probably looking for when it comes to this topic?
Yeah, it's a good question. I think it's going to be a point of major focus in a lot of newsrooms, both at the national, state, and local level over the next, month. I'm thinking back to last year's rollout of COVID vaccines, which in some ways was a lot simpler, right? It was controlled by the government. The supplies was bought and paid for. A lot of that process was already built out, And even in that process, you had all these stories that came out through local newsrooms of people who would go to the pharmacy and they gave them the wrong vaccine or the wrong formulation, or, they said, oh, actually, you should be paying for this vaccine when in fact they should not have been paying for the vaccine. Those are the kinds of snafus that maybe at the federal policy level, it's clear that the vaccine should be covered, but at the local level, when it comes to those overworked pharmacists or, private healthcare providers who are administering the shots, that, those are where the wrinkles come out. So I think that's going to be a big focus of our coverage going forward, that implementation of this essentially brand new COVID vaccine at the same time that immunization managers and healthcare providers are also implementing a new RSV vaccine and the annual seasonal flu vaccine. Separate from that, obviously, I mentioned before, the variant is going to be a big focus, I think, for us. There are early signs that probably this vaccine is going to do a good job at boosting protection against BA.2.86. That's, again, that highly mutated variant that some people have been concerned about. But at the same time, as has happened with previous variants, lab data and what you see in the real world isn't always exactly the same thing. And so that's something that I think a lot of experts are going to be following. And by virtue of that, that's something we are probably going to be following pretty closely too.
I think I saw something yesterday that said, excuse me, federal officials aren't even talking about a primary series, excuse me, of shots followed by boosters. Instead, they're almost avoiding using the term boosters and trying to steer Americans towards the idea of a single annual immunization. Patricia, what direction are we moving in? And it seems that at some point the public might be overwhelmed by, do I need to go out and get 4 shots this fall? Or how do we uncomplicate this for the public?
Well, I think, so first of all, it is true that we are talking about this as an updated vaccine, right? We're not talking about this vaccine as a booster to the last vaccine, right? It's a formulation that is new and it's newly approved. So that's one thing. What I would hope people understand is that you can have vaccines administered at the same time, right? So the important thing is for all of us to be able to share with, I look at myself as a consumer and as someone who's here with some expertise, but as a consumer, I have to make a plan for my vaccines, just like I make a plan for my vacation, right? So when am I going to get these vaccines? Which vaccines do I need? I need to do that in consultation with my healthcare professional. And really think about the importance of getting the vaccine in preventing, for myself, preventing an infectious disease, right? So I'm going to get my RSV vaccine, I'm going to get my flu vaccine, I'm going to get my COVID vaccine in this season. I want to also think about how that's impacting not just me, but it's impacting those around me, right? As I choose to get a vaccine. And I want to think about how that impacts us societally and economically. I think the thing that people forget about is absenteeism in work. When I'm impacted by one of these vaccine preventable diseases, we need to remember that some of us may not bounce back as well when we do get one of these vaccine preventable diseases. And so our activities and our function might change. So things like that those concentric value, the concentric value of a vaccine is so important. So when we talk about this, I think we have to talk about it as part of our plan, like we talk about our other plans that we consider for our health. and recognize, yes, there's a couple extra steps. I would hope we don't start to think of it in a way that it's so complicated that we can't do it. We have experts, we have our healthcare professionals, our trusted community members that we can talk with, right, to learn about what it is that I should do to get my vaccine. So I hope anybody walking away from here, both from the press perspective, right, communicating to the lay press, and for your own personal perspectives, think about the importance of making that plan to get your vaccines.
I want to take us back.
It's really good until it gets in your arm. It's much better when it's in your arm.
I want to get us back to the issue of the uninsured or the underinsured. Mario, with your role with the Opportunity Labs and your work as a health policy analyst, can you help us more thoroughly understand the importance of access for that group and how, lack of information may wind up keeping people from getting the vaccines they need?
Yeah, I think from a public health perspective, right, we've seen a number of trends with COVID. And what we've seen, I think, broadly speaking, are that, the disease burden and the bad outcomes are highest in older persons, people who are immunosuppressed and have, diseases that hamper their immune response. And then folks from lower socioeconomic status, right, who often have chronic underlying illness. And when you compound that with the challenges to reliable information and some of the misinformation that we've seen spread during the pandemic, I think that creates the sort of perfect storm for bad outcomes in that group, that last group. I think one of the other challenges that we've seen during this pandemic, and I think it's only been accelerated since I worked at HHS, is just how quickly the information echo chamber sort of operates. And when I think that you are a provider, a healthcare provider, or you're a federal official, your margin for a mistake is zero, unfortunately. But it's very easy for people to go on to Twitter or their social platform of choice and basically say whatever they like, whether that's about vaccines or new cases popping up or any of those things. And we know that information spreads so much faster among all groups than it does coming from reliable sources. And so what I worry about as a provider, right, is that information gets into those communities. And for lots of different reasons, it's hard to get reliable information into those groups. When you compound that with the institutional access difficulties that we know exist out there, that's, where we start to see bad outcomes. So, and that's why I think that the CDC's Bridge Access Program is critically important. It's an absolutely vital tool for making sure that these folks can get vaccinated if we can get them into administration sites.
Give us a little bit more detail about the Bridge Access Program.
So the Bridge Access Program was essentially designed to provide access to vaccines for people who didn't have eligibility under other mechanisms, whether they, didn't have Medicare coverage, Medicaid, private insurance, and they fell below other socioeconomic lines that prevented access to vaccines. And I think the program is just standing up. And so I think there are some concerns about how well it's going to work. Earlier this month, there were concerns about whether access to those vaccines through that program are going to be rolled out at the same time as access to for everyone else. I think that those hurdles have been ironed out, but that's a story to follow in the weeks ahead, and whether or not people in those age groups or in those groups, have been able to access vaccines through community health centers, and in particular through pharmacies, where a lot of the friction is, in the weeks ahead.
And if I could just, I'm sorry, go ahead.
No, you go ahead.
Yeah, and if I could just jump in on the Bridge Access Program. I mean, it's been interesting to see it evolve, right? Because, and I think the other co-panelists know this, but for a long time, in a lot of health jurisdictions, there have been, reduced or free vaccines available through health departments in some programs, through these federally backed community health centers in some locations. But there was this real gap when it comes to, for example, what we saw during the COVID pandemic, where anyone, regardless of their insurance status, could just walk into a pharmacy and say, I feel like getting a COVID vaccine today, and they don't have to jump through 10 hurdles to find where their closest health center is that's offering a vaccine they're eligible for. They could just find the closest Walgreens or CVS that has it in stock, right? And this was a key part of what the Biden administration said they hoped would be something they could guarantee through the Bridge Access Program, that with this new batch of vaccines that's coming through the traditional commercial market, those vaccines could also be available in pharmacies at no out-of-pocket cost to people without insurance, right? Because insurance is covering that cost of administering the vaccine. From what I've heard, that, and we'll probably hear an update about it at ACIP today. I think it's on the agenda, but what I've heard is that that program is not quite ready to stand up yet in pharmacies. You know, if you go to a health center this week, if you go to a health department this week that has placed an order for these vaccines, they might be able to give you that shot. In pharmacies, it's not so clear that that's going to be ironed out across the program. Initially, CDC had said that they were hoping to get the contracts kind of locked in with CVS and Walgreens by October. That timeline has been accelerated to hopefully this month. And again, we'll probably hear about it more at ACIP today.
It's very important information. You'll probably be hustling, Alex, over the next few days.
The next few hours. Yeah. Anyway.
The minute
Yeah.
we I think I'm going to go to some of the questions that have come into the chat because they're interesting and I think they'll help expand the conversation. We have one from Rachel Nania, I think that's her name. She's a former NPF fellow and currently works with AARP. And she's asking, will all Medicare enrollees be eligible for a booster for free, including those who are not enrolled in a Part D plan and those whose Medicare Advantage plan does not include drug coverage? Patricia, can you answer that?
Sure. So one thing is for the COVID vaccine, COVID is covered under Medicare Part B, as in boy. And that was taken care of during the public health emergency where Congress put this vaccine right into Part B. So Medicare beneficiaries will have access through the Part B program for with no copay or with no out-of-pocket cost for the vaccine.
Another question from Vincent Gabriel of Hearst Media in Connecticut. He says, to what extent is the lack of authority for the CDC to gather data and implement health rules a feature and not a bug? And he says by that he means, is this lack of clarity on outbreaks and illness by design? It's kind of a provocative question there. During the pandemic, there were numerous industries that rallied against COVID measures, and I worry that improving our health surveillance system is going to be hampered by these actions going forward. Mario, what do you think about that question?
Yeah, it's a super interesting historical question. And I would actually recommend that any reporters who are covering this actually go back and look at how CDC was originally founded. And there's an interesting backstory there between how CDC was founded and how NIH was founded, and sort of what the role of the federal government investigating disease outbreaks were and what the role of state and local governments were. And, you know, when, if we go back to the smallpox era, the original responsibilities for investigating public health breaks fell to state and these local health departments. And it really wasn't until I would say like the sort of post-World War II era that there came to be this idea that the federal government also had a role to play here. And the institutions of NIH and CDC grew up around that. But the original foundational structures for that continued to stay with the state and local health departments. And that's why we have, you know, more than 2,400 different health departments and localities that all have different reporting requirements and different responsibilities. And we haven't really addressed those foundations. And so, you know, that I think was what I was trying to say when I answered your first question. And that's why we have the data problems that we do. Because in some states, local health departments have a lot of authority. We tend to see that in some of the bigger cities like Los Angeles and New York. In other areas, local health departments are both underfunded and almost powerless. And they may answer to a state health department or some other authority. Sometimes they're not even rolled into, you know, other departments. And so, you know, the question of whether it's a feature by design, I think the answer is yes, but it's time for us to go back and revisit that design because it's clear that it's not working anymore. And so going forward, you know, I think that is a key impediment for us as we start to look forward. I think those same voices that challenged data collection and the legal authority to do that during the public health emergency are likely to come back up. And we absolutely have to find a way to address that from I would say, a legislation perspective.
One of our
Rachel, if I could add, one thing for the Adult Vaccine Access Coalition, this is really a key role in our mission around access to vaccines, is being able to provide that funding for collection of data and for synthesizing that data and making it available, right? Making it available for consumers, patients, to have access to your own vaccine information, as well as for public health, as well as for practitioners, thinking about how much we're more mobile, right? So, we live in the DC area. It's quite possible that I could see a physician in Maryland, get my vaccine in DC, and go home to Virginia at night. And so the importance of that system really can't be underestimated.
And if I could just add one more thing on this too. Yeah, it's COVID is a great example of how, you talk about by design, right? On the systems level, obviously there's substantial hurdles that need to be overcome in order to connect the records and collect all this information about, who is testing positive for COVID and who is in the hospital, and tracking those trends. And at the same time, though, especially with COVID, on the other end, you have this question of how that data is coming into the system in the first place. The big thing, for example, is whether or not a doctor in an emergency room or at admission at a hospital is going to swab you for COVID in the first place is very different now than it was a couple months ago or a couple years ago. And so when we're talking about, improving the data to track, pandemics and outbreaks and emergencies, it's not just, the top level systems that is collecting all that information and sending it up to health authorities, but it's also that ground level perspective of, how are we actually looking for infection? There have been some CDC officials who often talk about how in the United Kingdom during the COVID pandemic, they essentially had a nationwide ongoing survey that was randomly sampling proportions of their population and saying, do you have COVID? What are the symptoms you're having, et cetera? And from that, they got a lot of interesting information about the virus and its pathology and vaccine effectiveness that we couldn't do here because we don't have that system set up. So again, it's both the output, but also the input.
We have a question from Jackie Fortier of Southern California Public Radio. She says, if ACIP doesn't recommend the shot for 12 and under, for example, what does that mean if the FDA has broadly approved it? Will rich people be able to pay to vaccinate their kids while it won't be covered by insurance for everyone else? Patricia.
Well, okay. Yeah, I was just going to say that, one thing I wanted to mention earlier, and then it slipped to my mind, is, we actually asked CMS about this. And it's interesting because I think depending on the lawyer that you talk to and the person that you talk to who's interpreting the legalese around this, you get different interpretations. But CMS's position on this is interesting. They think that essentially that original ACIP recommendation from earlier in the pandemic is enough to trigger and again, this is getting in the weeds here, but is enough to trigger a CARES Act requirement that vaccines be covered. And so under that interpretation, they think that essentially all vaccinations that happen following the FDA authorization or approval should be covered by insurance, regardless of the ACIP recommendation. So theoretically, that could mean that an insurer should be required to cover a shot that's given to a person under 12 years old, even if the CDC doesn't necessarily recommend it. Now, again, I'm not a lawyer. This is, we're kind of going into uncharted territory here. But the short answer is CMS's position right now is they think it should be covered if FDA authorized or approved, end of story. And that's all resting on a CDC decision that happened actually earlier in the pandemic.
Patricia, did you want to add anything to that?
So I think Alexander has more updated information, and I think that that's something that we need to continue to ask about. And I think that for one thing, we do follow this very closely to be able to get information like that. And what would be really important for us to see is CMS release a guidance that defines that for all of us as we move forward in practice.
And I'll just add that I think these are the kinds of questions that probably, depending on how today's ACIP meeting turns out, I think a lot of people are just hoping, ACIP recommends it, broad recommendation, end of story, everyone moves on. But if we end up in that situation where it's, the 12 and under isn't covered by the recommendation, or there's like a weird shared clinical decision-making thing, I think that's when we're going to start getting into that, the weeds of who is actually required to be covered and when, and, are providers going to be offering it? And there's a whole separate thing about this on, liability protections for vaccinators that happen under the PrEP Act that are tied to ACIP recommendations. But I think probably a lot of officials right now are just hoping that ACIP gives a broad recommendation and we don't have to go into all of these questions.
So
the journalist for that possibility, Alex, because it isn't going to be just a one size fits all response. Patricia,
the one thing I wanted to add, and Alex, you mentioned shared clinical decision making. I think we need to remember that that's an approval by the ACIP, right? So what that means is you have a conversation with your healthcare practitioner, right, to discuss the merits of the vaccine. That's ACIP approved, and that should follow the trail that once the CDC director approves that recommendation, then the vaccine is approved, right? So I wouldn't want any listeners to go away and say, "Oh, I can't get the vaccine because it's just shared clinical decision." It's really what you want to do. You want to have that conversation with your practitioner and say, "I think this vaccine is right for me. This is why. What do you think? How do we have that conversation?"
We do have a few questions from international viewers, and I wanted to get these in. One, John Omonding of Uganda Radio Network says, does the CDC oversee innovation of vaccines from any part of the world, all over the world? Mario, could you answer that question?
I need to look into it in more detail. I don't believe that they do. CDC partners with international countries and has offices in international countries and conducts research in partnership with other countries, but they don't provide safety oversight, to the best of my knowledge, about recommending vaccines in other countries.
Well, since you mentioned the word partnership and collaboration, Milton Aquam of TND News wants to ask Alex, what is the biggest challenge that came your way at the peak of the pandemic as a journalist? And how crucial was the power of collaboration, especially in getting data from Africa and low-income countries?
I think, it's two questions, right? First is the biggest challenge by far. It remains to this day, but it was worst at the peak, is just the sheer amount of information that's happening, on all of the fronts: vaccinations and variants and treatments and policy and requirements. And, it was just so much coming that was hard to handle as one person. And that's where collaboration comes in within your team. As it pertains to international collaboration, definitely. I mean, with all of these, just to take variants as an example, with all of these variants, it has been the open sharing of data and findings and information across borders from other countries, from scientists who are seeing some of the earliest cases of the, XYZ variant, insert the name here, that has been so crucial in helping journalists here sort out on what should we be thinking about this virus? What should we be asking our officials about how they're preparing for, the insert the name of the variant here. And that has been so crucial. And it's something that I think only has been able to happen because of not just obviously information sharing over the internet, et cetera, social media, but also the willingness and the funding that is needed to go to these scientists to be able to generate and share that information.
I'm going to ask each of you to respond to this question. It's, do you feel that the CDC should update its guidelines on exposure, testing, and masking? Should people act the same way as they have over the past few years of the pandemic? Mario, what is your response to that?
That's probably the hardest question that's been asked so far, and I don't know that anyone knows the absolute right answer to this question. I think that in medicine, our job is to provide the best recommendation based on the information that we have at this moment. And one thing that I have consistently said, throughout the pandemic, particularly as we've heard folks call for mask reinstatements and some of these things, is that the purpose of all of these response measures that we take is to hopefully get us back to normal life at some point, right? And for all the reasons that we talked about earlier, right? The disease burden being lower than it was, the number of deaths being quite a bit lower than it was. I don't favor the reintroduction of masks right now. What I favor is a risk-based approach based on the number of hospitalizations that are happening in each county, similar to the information that CDC provides. But that is extremely nuanced information that's very hard for the everyday consumer to internalize and think through. And that's where I think we have some progress to go in terms of simplifying these guidelines. I think it's not enough for us to simply say, everyone should wear a mask, everyone should continue to test all the time, and this is how we're going to continue to live our lives going forward. Clearly, an overwhelming majority of America is tuning that message out. But at the same time, we have to find a way to incorporate those data-driven recommendations into something that can be easily consumed.
Patricia, what are your thoughts about that?
So I think Dr. Ramirez, that was very well said. And the importance is to think about people I hope the public continues to recognize that as the science, as the evidence is before us, we continue to evolve. That's the important thing to remember. As new evidence becomes available, we adapt and we adopt new practices. And so it's not something that's stagnant, as of January 1st, this is what we shall do for the whole year. And hopefully our ability to move from a public health emergency to how are we moving forward, understanding that COVID is now part of our lives, that members of the public understand that. It's really important for us to recognize that if new information comes to light in October or in November, ACIP will take that into consideration. CDC will take that into consideration. Public health officials will take that into consideration and apply best knowledge and best evidence at the time. And our flexibility is important here.
We have a viewer who needs to get some specific story hunting advice from Alex. She says, how will we know if the CARES Act covers it? Will insurers refuse? And at what point should I poke around to see if that's the case?
Well, my suggestion is to start poking around once the vaccines arrive in the pharmacy, right? We heard this the first time before there was any of this legal complication of whether or not the insurers were going to cover it. You heard essentially these stories of consumers, residents, your viewers, your readers, your listeners who were going to the pharmacy. They want to get the vaccine and they couldn't get it for whatever reason. The pharmacist would say, oh, in my system, it's saying that it's not on your plan's formulary. And the person's like, what is a formulary, right? So those are the kinds of things that are, I think, going to be happening to people who are trying to get this vaccine over the coming weeks. That's a story that I think definitely needs to be covered at the local level, because that will vary depending on not just the insured that people have, but the actual vaccinators in each region. Separate from that, I think there is going to be a larger question, especially as we get into these, colder months, that, I really encourage all the journalists on the line to be looking into, which is how insurers are going to be handling who is in network to administer these shots, especially when people are going out to get 3 different shots. You heard Patricia talking about it earlier, but we have a COVID vaccine, we have an RSV vaccine, and we have a flu vaccine that for some people in some age groups, like older adults, technically they might be recommended to get all 3 of them, depending on a consultation with their provider. But is it possible they're going to go to that provider and they're going to say, I think you should get all 3 of them, but I only have 1 of them, and you should go to this other person to get another one, or I want to give you this other one, but unfortunately this one is not in your plan, but I can give you this one, but you're going to have to pay out of pocket. Those are the complications, especially for adults and children who are recommended to get more than 1 of these vaccines and potentially all 3 of them, that I think are going to need to be sorted out over the coming months. and are definitely something you should be talking both to your audience to hear what their complaints are, as well as to the health officials and to the health, essentially companies and providers that are in your area and how they're implementing these policies.
We are starting to wind down now, but there is one important question from Cheyenne Haslett of ABC News. And I'd like Mario to address this, if you would. Can you expand on the potential concerns around the Bridge program? Should people expect pharmacies or community health centers to have vaccines for the under or uninsured later than those who have insurance?
So the primary rub, and I think Alex did a great job of outlining this a few minutes ago, has been around private pharmacy chains providing administration of these shots to folks who are eligible under the Bridge Access Program. The way that the reporting has focused on this is, I understand the state of affairs. If you qualify under the Bridge Access Program, you will be able to immediately, once the vaccines are available, go into a federally qualified health center or a community health center and get one of these vaccines, assuming that they have them in stock. The question has been whether somebody can go in and receive eligibility to get these shots at a private pharmacy chain over the next 2 to 3 weeks. That, as I understand it remains to be sorted out. And so what we may hear are that folks who are trying to access vaccines under the Bridge Access programs at places like CVS, Walgreens, Rite Aid may run into trouble. That's what I think we're going to hear more about today, per Alex's point.
As we wind down, I think this is a good opportunity for each of you who are so steeped in this issue and can help our viewers understand the importance. I want you to really give us your top line statement about how media should be reporting on this issue of vaccination. Is it something where the focus on the older and immunocompromised people should be a stress? Can people get vaccines at the same time? How to avoid misinformation? I'm going to start with you, Patricia. If you had to sort of give that bottom line on what media should be doing and reporting on this access issue, what would you say?
So I think it's really important to remember that vaccines save lives. If anybody could walk away from this, next to us being able to have clean water systems in the United States, vaccines are the next level of impact in public health. So I hope while we may find challenges in different places, and we have to keep asking questions and we have to keep advocating for access to vaccines, I hope that we remember that doesn't mean that we turn around and walk away and just say, I'm not going to get my vaccines. And so making sure that we continue to provide the information for where people can go when they're having a challenge getting access to a vaccine, making sure that consumers are talking with trusted members of the community about information about vaccines is key. And so for COVID and for all vaccines across the life course, right? So from birth till we are no longer eligible for a vaccine because of death. I want us all to remember that vaccines save lives, and they're a very important part of our public health system.
Alex, how about you? What sort of top line message do you have for your colleagues, journalist colleagues?
Yeah, I think the biggest top line message is that this time it's different, right? And you've heard us talk about it a lot today, but the previous COVID vaccine rollouts up until this point have all been through that government bought and paid for supply chain. The government paid for the doses. They went through that supply chain that came with a lot of strings attached to make sure that they were given with no hitches, and yet hitches kept occurring. And now it's very different. We're in essentially what people like to say the regular traditional commercial market. And in some ways that's familiar, but also in some ways that's going to be very different for a lot of people. There are going to be people who are going to be going to the same vaccine they got, COVID vaccine, primary series and booster shots 1, 2, 3, 4, and 5. And now they're going to go for number 6 and they're going to say, oh, actually, now we are not in network for you. You should go to another place. Those are the kinds of changes that I think are going to be filtering down to consumers as they're trying to get their vaccines, trying to get their booster shots. And that's something that I think, is going to be something that's going to be important for us to follow as people are encountering these challenges, helping people understand not just why these are happening, but also how they can troubleshoot them and overcome them, especially when, potentially not doing so means they're just not going to get the vaccine this season.
Mario, we started this conversation with the sort of message that it's estimated that 9 out of 10 people will have this access. But when it comes to how the media really parses that out and helps people to have a really contextual understanding of this, what advice would you give?
Well, if I exchange my analyst hat for a second and wear my ER physician hat again, I would say that Trish made a great point. And as a physician, the way that I wish the press would report on this is to say that there are no magic bullets for COVID, right? Vaccines are a critical part of a layered response for everybody, but that includes getting tested if you feel sick, and then going to see a doctor and get a prescription for one of the antivirals. A lot of people would like to think that if I get a vaccine, I don't have to worry about COVID anymore. That we know that that's not true. We know that there are serious breakthrough infections that happen. A lot of people would like to say, well, I already was infected and recovered, or I got vaccinated before, and so I don't need to worry about getting vaccinated again. And, I see people who fall into all of those buckets in the ER. And the truth is that serious COVID happens among people who have been previously vaccinated, just got boosted, people who've been infected and recovered. There are no magic bullets against this virus. And it's important for people to stay aware and think through each of those steps and come see us in the emergency room or see your doctor if you don't feel well.
This has been an incredibly important and timely conversation, and I'm sure we'll all be looking to see what the advisory committee releases later today. But I'd like to take this opportunity right now to thank each of you, Patricia D'Antonio, Mario Luis Ramirez, and Alexander Tin, for really giving us a solid baseline and beyond understanding of what we need to know about vaccine access moving forward. So thank you all so much for joining us. And I'd like to tell viewers and listeners that you can go to our website at nationalpress.org for more information about this topic. We'll be posting this video online and also on our YouTube channel. But we'd like to thank our sponsor, the COVID Vaccine Education and Equity Project, where you can also go and receive a tremendous range of resources about vaccine access and other topics that you need to know. So thank you from the Evelyn Y. Davis studios of the National Press Foundation. Thank you all for joining us.